So Chelsea, you can either sit here or the 3 seats that are left here. You're probably How about now, Taylor?
Casual today, buddy. Dress down a little bit for today.
Okay, why don't you say something, Taylor, so we can make,
I got you now.
Thank you. Sorry about that.
okay, so sounds like we're ready to roll. Just for the record, Assembly Member Dave, brain dead here, Ken Singer just came in, so we can start. Thank you, Phil.
Did anyone have anything that they wanted to add to this working agenda or work session?
I didn't see anything.
See if I can try to get this show going. And I did provide some handouts. So what I thought I would do is just provide a summary of maybe where we left off with the work session in the past, and maybe give a little.
Move over here if you want to.
No, I can see. I'm good.
Oh, I'm sorry.
And then here's the agenda. And so we I worked with Bob, Lynn, and our board on this, and basically we like to cover the new hospital facility, a recap of the master plan for Petersburg. And I did bring a copy here if anyone would like to take a look at it, but the borough also has a copy that was provided. Let's see, we just a discussion of funding for a new facility, potential funding, some next steps. And then I also like to cover some of the operational overview and functions of the hospital a little more in detail than I normally do in an assembly meeting, just to give you a perspective of the last year. And even I went back to 2006. So you can kind of get a perspective of the history of the facility and the operations and services. And, you know, it's a working session, so feel free to interrupt me anytime. So I spent some time, I kind of enjoyed this slide. It's a little bit small for the screen, but I looked at the archives in the pilot, and I'm very fascinated by the history of Petersburg Medical Center. It's got a great history, and the foundation was Petersburg Hospital Association was formed in 1917 as private citizens, I believe. And then in 1921, the town, at the time, it was a town, not a borough, took over the Petersburg Hospital at that time. So literally it's 100 years to the day, or not to the day, but to the year, I suppose. In 1945, there was some funding. I believe it was House Bill 54 that had been passed and provided some funding for to have a new facility. And in 1955, that 10-year span came to fruition. So I believe it was $25,000 that was granted through that House bill for healthcare, health facility. And then it was another $100,000 that came up through grants, and the rest was made up for the within the community through their hard labor and donations, and to a total of about $200,000. And that old site is the current location of the hospital today. It's actually the old part of the hospital, and it was long-term care is that function now, but it was just a traditional hospital at the time. Acute care, ER, those things. In 1975, there was some funding that was obtained to build a long-term care wing. So the long-term care wing was built at that time. And then according to records in 1979, discussions for a new facility were ongoing. And then in 1983, there was some funding at the state, about $10 million, I believe, for a new building. And it basically was a renovation, a demolition, and some new structure of the current building to date. And that's what we see today, is basically that structure from 1983. And then we are probably in the late 30s to 40-year lifespan of that building. And roughly, from what I could tell, in about 2012 is when there started some conversations in the community on maybe renovation. There was a plan that an architect firm put together in 2013 about potentially a new long-term care building, and some concepts of renovation. In 2011, I believe the primary care clinic, Troy Jansen Clinic, was remodeled. So I think from that time span to today, 2012, 2015, there was a facility feasibility study done, or assessment done by a firm, JYL. And then I came on the scene in 2018. And under direction of the board, one of my priorities has been a new facility. So that's where we are today. In 2019, I was able to obtain Denali Commission funding for a master plan, and basically to take the elements that have been done in the past 10 years or 8 years at the time, and come up with a final document on the assessment of the structural assessment of the facility. And that all came up in these two things of a financial plan. We hired a firm through a bidding process. The name of the firm was NAC, and they provided all the elements: inundation study, debt capacity study, financial feasibility, structural analysis, and seismic study. And they made some recommendations at that time, and those recommendations were put forth in a town. Well, first we met in December 5th, I believe, in 2019 to discuss those with NAC, and that was the last time we met. And then in January of 2020, we had a town hall meeting presentation that discussed the Petersburg Medical Center new facility and recommendations, and then COVID hit. So that's the summary of. Did I miss anything? That's 100 years worth of commentary, so my apologies. So working forward, some of the things that I've been working on since starting is establishing a strategic plan with the Peterborough Medical Center. We've had, this is our third work session, which is very exciting. A lot of the elements of the work session have been around the new facility, so continuing that conversation is very important. Before COVID, I did 3 or 4 community cafes, can't recall now, talking about the services of Petersburg Medical Center, providing education to those services to the community, and also obtaining input from the community on services that they would like to see. And the last one we did was November of 2019. It was about aging in place and talking about different modes of services that the community would like to see in the future. We had, I report out on the assembly meetings monthly, more so now, obviously, since COVID. And then I talked about the town hall meeting, and we'll talk a little bit more about some of the takeaways. Okay. So this slide does get some input. I've seen this presented a few times. It's the budget. It's not, I hope you can see it on your paper sheet, but I just want to explain the budget a little bit. The way that NAC calculated the budget, it comes up often that this is an $80 million building and this is a $90 million building. And there was 3 options that were selected for cost estimate budgeting. And, essentially with some further analysis and space programming, I'm sure that number can be trimmed down a little bit, but basically that's turnkey. So the budget number you're seeing is laid out so that you see the site preparation as an amount, the construction costs as amount, and then in that budget, there's a percentage that's calculated for FF&E, which is furniture, fixtures, and equipment, and some inflationary costs and supply costs. And those are estimations and percentages. I had somebody take a look at it and refine that a little bit more and looked at zero-based budgeting instead of the percentage. And roughly it comes down to about $1,180 per square foot for costs, basically anywhere that you look at it. It's actually more expensive if you try to build in place in the current location and around the constraints of a facility instead of a greenfield site. So that's a general cost. If you look at sort of the Wrangell building as a reference, it's almost identical to the Wrangell building. Theirs is 40,000 square feet, and I believe theirs was roughly around 40 million cost, and that's roughly about $1,000 per square foot too. So it's right in the same ballpark as other healthcare facilities.
Bill?
Yes.
On the original master plan, you had 5 potential sites. And
Right.
now it's down to 4.
I think it's down to 3 because I don't believe the current downtown location is a viable site.
see,
It's
okay.
it's very expensive. And then the site that I X'd off there, that South Hogan site, it has a ravine, and I think it'd be, I think to move the environmental studies along the other three locations were probably the most viable based on utilities and what's available there.
Yeah, thank you.
Bill, when you talked about Wrangle at $1,000 a square foot, are we talking about comparable services?
You know, I don't really know the details of Wrangle. I just know the project costs are public, so I was able to look that up, and I did ask one of the executives a while ago what the project costs were and the square footage and the design. And they had a primary care center in place already established, and then they built the hospital next to it. So it's a little bit different.
Phil, and I assume from the map here, what I can tell, these are parcels that are currently owned by the borough, correct?
That is my understanding. Before I came on, these were provided by the borough as possible locations.
Okay,
Yeah.
thanks.
Okay, so under the agenda, there was a discussion point on just kind of touching upon an outside entity versus keeping a Petersburg community facility, and some things to consider. There's actually some good published data out there. I did reference it at the bottom. Petersburg community, the hospital obviously has a long history. Locally owned, local workforce, locally operated, locally controlled, and local economic impact are all things that lead to having a community hospital, in addition to continuity of services and control over the types of services you'd like to see. So there's a lot to be said for a local community-owned facility or community-run facility. An outside entity that came in, you don't really have control on service lines. You don't have much on decision-making. A lot of the scale and economies of scale are outsourced, or they scale it at the higher level. So a lot of the economic value kind of goes outside of the facility locally, potentially outside of Petersburg, and there's potentially some lost interest as far as a large organization. I worked for a large organization that had 15 sites. I can tell you it's very difficult to pay attention to all the sites and provide the services that each community deserves. And I think that's something that would be lost with an outside entity. And so those are just general bullets, general topics on covering that. I don't know if there's any discussion that we wanted on that at all.
Sure, Phil. I'll flip the script for the sake of the discussion, because that's what we're doing, I guess. The advantages of a Petersburg community facility, no argument for me. What are some of the inherent challenges that come with a community-run hospital? Maybe just for those listening at home, or for us as well, if we haven't considered them.
Yeah, any community rural hospital has staffing challenges are probably the biggest.
Sure.
So having if you hear me talk about the value of the facility, I talk about the services provided, the quality of care, and that comes from your local workforce. It's very difficult to have a workforce in rural areas, and so that becomes exponentially more difficult and more expensive to secure if you have outside firms coming in. Physicians are a good example of that. Some rural areas, actually, I can speak from experience. A lot of times physicians are in contract. They are 2 weeks on, 2 weeks off. A lot of the structure of that schedule, those physicians aren't invested in the community as much. They're not buying local. They don't own their own houses. They have hospital housing. They don't own their own cars. They're shopping not as much in locally in the community. So you really want a workforce that is living here, that has a family here, is basically invested in the community, and that also has direct impacts to the care. So I would say staffing is probably the most challenging in any rural community.
That makes sense. Thanks, Phil.
Yeah.
I have a question. I mean, at least what I've read, and I could be very much incorrect on this, is that rural facilities are evaporating across the country right now. I mean, they're just going away at a rapid pace. I can't reference the article that I read it on, but my question is, are we biting off more than we can chew? I mean, going forward with the uncertainty with healthcare as it is in our nation right now.
Yeah, you see a trend of big organizations taking over small organizations is one trend that you could potentially see. And the other trend, the community hospital in general is definitely not a growing trend. And you have bigger entities taking over and scaling operations. I have talked to a number of entities that have done that. I've also had seen, or, I know of some places that close critical access hospitals. There's been some closures in the late 90s, early 2000s. There was a trend of difficulties there. There's some structural cost base, like the way that the calculation for finances has changed in the late 90s, and they changed the designation to something called the critical access hospital. And by having that critical access hospital designation, which we do, you're allowed to have cost-based reimbursement. So you have a better chance of having financial stability by using cost-based reimbursement. And so basically what that means on the Medicare side is you can look at your expenses for operating the facility in certain areas, and there's a calculation, it's pretty complex, but your expenses get, it's like a true up system with Medicare. So if you have a year where you're spending more than you're taking in, Medicare will pay you back. If you have a year where you're making a lot of money on Medicare, you'll end up paying them back. And so it's kind of almost a cost neutral situation for critical access hospitals.
So, just in my observation of the budget, it seems like the driver of the income for the facility is long-term care. And what's your feeling on the stability of that as a revenue stream going forward? Because without that, it doesn't really pencil out in my mind.
I will, I'll touch upon the operations a little bit. I think that is in older, that's not incorrect to make that statement, but it's not also when I look at forward thinking and operationally making things viable. I can show you some of the things I've been working on pre-COVID, obviously. And a lot of your business opportunity and capture comes from your clinic, in your primary care clinic, which is attached to, it's not like other locations where your clinic and your primary care center is not attached to the hospital. Our rural healthcare hospital has long-term care, it has inpatient, it has ER, and it has a outpatient clinic, outpatient treatment. It also has a primary care clinic. So the physicians work in the clinic, and then they also walk over and they see the patients in an inpatient unit. They also are on call for the ER, and they also see the patients in long-term care. So that makes it very economical. That is not the norm in lower 48. A lot of times lower 48 facilities don't have that. Primary care centers are not attached. Actually, a good example is Wrangell. The primary care center was a federally qualified healthcare clinic that was separate from the hospital. And that's a competing interest. So you have physicians and staff in one side, and then you have additional physician staff on another side. And that becomes very challenging in the small community to make ends meet on that. We don't have that. We have great economy of scale. We have great services. We have additional services that help with that cash flow issue. Unpredictability is hard, like long-term care, inpatient, ER are relatively unpredictable. So how do you do predictability models with that financially? So one way to do it is look through the clinic. The clinic is your access, your prevention services, your follow-up, your access to chronic disease and patient-centered medical home models, wellness models, things like that, mental health, grant-supported services through that. And you'll see some of the trends when we're building that in the future. There's a lot of potential with that. So I think long-term care certainly makes things viable, but it's not just the only thing. There's many, many things that we are doing and would like to do and grow within the community that I think make us way more marketable than the traditional critical access hospital.
So I guess my concern is it wouldn't take a big change in Medicaid formulas to severely impact the revenue stream of the long-term care facility here. I guess that's my concern. And of course, nobody has a crystal ball. Nobody knows what's going to happen in the future. So you have to go upon facts as they are on the ground now to a certain extent. But
When you say Medicaid calculated, what do you mean? Because we have a third Medicaid, a third Medicare, and a third private pay, and then we have third.
right, yeah,
commercial and
I don't
third-
know. I haven't looked at the breakdown of how the long-term patients.
Long-term care is Medicaid primarily.
Yes,
yeah,
that was my understanding. And that's my concern, since that's the main driver right now of your budget or your income.
I don't think
currently.
it's not, I don't think it's the main driver of our budget.
Okay,
Yeah, it's a driver of our budget, but it's not the main one.
not the main one. Okay.
Right.
So in other words, I guess my question is, you feel comfortable, at least knowing what we know now, that we'll be able to maintain our reimbursement rates for Medicaid and Medicare? Because if we're talking about building a multi-million-dollar facility, we have to have some assurance that we're going to be able to get this money in the future. Otherwise, it doesn't pencil out.
So it looks like we're gonna jump ahead to the finance discussion. So.
Yeah, okay, I'm sorry, I'll
and
stop.
No, I'd be
I'll
happy
stop.
to, no, it's a good time for the
Yeah.
question, and I'm gonna probably ask Cynthia, our financial consultant, and or Ro to speak to some of the finances. Cynthia, are you on?
I'm on, yes.
All right. Do you want me to jump to a slide that explains some of this, or do you want to talk about capital add-on, or how do you want to handle the question?
Well, actually, I can, let me start without a slide, and then we can go to the ratios if we need to, but we'll start with long-term care because it is a good question, and I'll try not to get too accounting-ish on this. But the long-term care, absolutely, when we look at our financials and we see that there are a lot of dollars. Long-term care is one of those areas where it's a relatively low volume, but very high dollar in terms of the gross revenue and the cash coming in. And so it's a really great question about whether or not that's a foundational to the profit of the organization. And it's kind of interesting because, as Phil said, long-term care is almost 100% Medicaid. There are some other payers in there, but it's traditionally all Medicaid. And theoretically, the way Medicaid reimburses PMC is we get paid back 100% of our costs. So if you think about it, and without getting too far into the rate setting and how Medicaid works, but theoretically, from a profit standpoint, if we're reimbursed our costs on the long-term care, then you can almost look at long-term care from a profitability standpoint as a break-even type operation. So if that helps a little bit on the contribution of long-term care. Now, the way Alaska sets rates, which are done every 4 years, those rates are set based upon the rate setting year census. So in between rate setting years, which are every 4 years, to the degree that you do better volume wise, that's when it can really benefit the organization from a profit standpoint, because Medicaid doesn't do any type of settlement. So they'll calculate, what are we going to pay you for a resident day based on that every 4th year. And if your census is better, you'll continue to get paid, even though your costs may not go up during that time period. But generally speaking, it could be viewed as, it's cost-based reimbursement. And so all things being equal, it would be a break-even type operation. Secondly, because of the way we're reimbursed, and we're reimbursed cost for Medicaid and Medicare, what will happen, regulatory changes aside, is that the rates that PMC receives from Medicare and Medicaid will actually be recalculated after a new hospital is constructed, and those rates will increase based upon the 2 factors. One is ongoing operating cost each year relating to the new facility would be picked up in part by the Medicare and Medicaid reimbursement. And then also there's a one-time capital add-on rate for future depreciation on the building. So the construction costs relating to the new building actually get included in the Medicare and Medicaid rate setting. So there's a portion of that construction cost that would actually come back to the organization through its Medicare and Medicaid rates. So does that,
Yeah, that helps. Thank you. That clears a lot up.
And so one of the things that and it looks like Dr. Hess had mentioned there, the other thing to consider with long-term care is that a new facility would be set up in a much more attractive and resident-friendly way. I mean, certainly since I've been here, I can't tell you the comment, I mean, the amazing, but the comments about, how old it is and its institutional appearance, and it's not set up like a home, really challenging, because in order to make it attractive and value-based for that, I think to me, a new facility it's necessary. When we talk about continuity of care, the conversation should be about how can we make this happen, not how we can pass this off to another entity to make this happen, or maybe it doesn't happen here. You don't want the better care is going to be the organization and the facility that has care in your home. There's something where if you went out and you got your knee done, and they found through studies that the better rehabilitation is if the closer to home you are. So we actually have a program, it's called Swing Bed. It's kind of a weird name, but the idea is through our physical therapy department, rehab, you come back into our facility and you can spend upwards of 30 days or more rehabbing your new knee until you're better to go. And the Medicare recognizes that the closer you are to home, the better you're going to recover. If you're in Seattle somewhere away from home, you're not going to recover as much. So locally based services is critical in the care in the community. And those are proven time and time again. And one slide I'm going to show you is and I mentioned the community cafe about aging in place, because there's a really interesting trend that happened in the last year. And that is services outside of the facility and in the home. And that just exploded as far as home care services, home health services. And we will look at care in the home. Wouldn't we want to receive care in the home? And not necessarily, even if you're qualifying for home health services, and if you're in that area, or whether you just want to receive some kind of services closer to home or in your home in some way. And that sort of aging in place model and that home health model, I think, is sort of the future of healthcare, not taking services so you have to get into a flight and go someplace else. But locally based care is even more important now than it is in the past. So sure, yeah, if you want to look at outside trends, if you want to have a scaled operation, I have a slide here where I just feel like that healthcare is not a commodity to be sold to the highest bidder. I really feel strongly about that. I worked in an organization. We went from very locally based care, and we became a huge entity, huge corporation, lots of funding. And I could tell you that it was quality-wise, I felt better about doing my job when it was a smaller organization and we were able to really deliver the care in a quality metric and not having 2 week on, 2 week off, even if we could afford it, staffing. And staffing really came down of care in the organization. So it's one of the reasons why I chose to come here. Because of that, because it's an opportunity. I talk about it because I went through a new facility. I went through the growth spurt that comes with a new facility. I went through staffing increases, and I always thought in my mind, if I could do it over again, I would do it this way. And that's why I'm taking a lot of time to spend about some of the operations, some of the way that prevention, patient-centered care, looking at healthcare staffing and resources within the community locally as really the solution before thinking about outside entities or scaling or economics of scale or non-locally based run facilities. kind of jumps into this, just to kind of give you an overview. We've had some growth in the last couple of years. So we have salaries and wages. We have about 95% of our staff live in Petersburg, and that economic impact, we have about 155 employees. In the last year, we've grown because we've had to direct a lot of our resources towards COVID and directed towards our response to COVID. And that's approximately 20 employees, doing screenings, airport testing, respiratory clinic, lots of additional services we've had to add because of COVID. And then we also had some indirect services like mental health expansion, home health that we've had to address that we increased as well. We have about $11 to $12 million of direct cash from the salaries and wages that go back into this community. And that's my bullet up there about healthcare is not a commodity to be sold to the highest bidder. So the other thing, I think that, let's see, any other bullets here. I am asking the assembly through the board on behalf of the board to fully support a replacement facility as recommended by master plan. And so I'm going to talk a little bit about next steps on that, but I do want to take any more questions or discussion if there are any. Is there anything that Jared or Marlene that you want to add, or Cindy, George?
So are the long-term beds, how do you determine how many long-term care beds you have?
It's a good question. There's a couple of ways. If you're going to do a new facility, you apply for something called a certificate of need. In the master plan, they actually look at like aging population, what your current census is. I'll show you. Let me jump ahead to a slide. I'll show you the long-term care so you can kind of see. All right, so this is our long-term care slide. I went back to 2006, and it's really stable. It's an average of 12 general, 12 beds. We have capacity for 15 beds. Our staffing, because of the way the staffing crosses over into the inpatient, the ER side, 15 is a lot for our facility. 12 is average, and that's a good number for our facility. The yellow bars are the decrease in the last COVID year. We've seen a decrease in census for sure, and that's a statewide issue as well. And I could show you a counter slide for the home health services that have just exploded. And I feel like that some of the care is being met in our home health or outside the facility in some way. So the two yellow bars are the 6 month, well, from March until end of June in 2020, and then 2021 fiscal year to date is the two yellow bars. But generally speaking, going back to 2006, I've even looked at data pre-2006. It's about as even as you can think, and it is a aging population. So when in this study, they thought like that we should go up to 18 beds is what they recommended in the master plan. I'm not necessarily sure I agree with that. I think if we're averaging 12, I think 15 gives you a couple of more beds for capacity and growth. But that was the determination from the demographics.
Thank you.
Yep. Phil, when you had the community cafes, what was the couple biggest concerns that our local publics had that relate to what we're doing here?
The community feedback from the new facility.
No, the type of services they wanted, and then how that would play into where you wanted to go, if you might.
There was a really strong recommendation from the Aging in Place Community Cafe on home-based care, home-based services. Yeah, we actually had somebody stand up and talking about therapy services and that were provided in the home. There's definitely a strong need and desire for that, and we saw that, and that's one of the graphs I'll show you. We saw that in this past year where we're delivering a lot of the care in the home.
Just to clarify though, Phil, I think that was additional services desired, not the desire to replace
Correct.
long-term care beds.
Oh, that's correct. Yes. Yeah, you still need long-term care. I mean, if you want to keep your grandmother, grandfather, an elder in the community, you need long-term care. So they're not, that's for continuity of care. That's what you want.
Phil, do you think, you mentioned in the master plan, they suggested 18 long-term care beds. Do you think that was a financial?
I think they were, the way they
Reason?
calculated that, I don't know, Cynthia, if you can, or Ro, can you correct me on that? But I think that was a demographic calculation, looking at aging population,
Okay.
Petersburg, and then the national growth factors of that, I believe.
Phil, do we have very many people from outside of the community come and utilize our long-term care beds?
We do. We've had folks from all over the state. Yes. Since I've been here, we've had, folks from Point Hope, from out in the Bethel, YK area, Kotzebue area. We've had residents from all over the state.
So if we were in an under capacity type of situation, it's not out of the realm of possibility to, I hate to say recruit, but to make it known that we have space available and we can fill that up.
Yeah, there's a Jennifer Breiner's on it. She can speak to that quite a bit. There's a group in the States very close to, Jennifer, are you on? Do you want to talk about that a little bit?
Yeah, I'm here. We absolutely accept and have admitted a lot of people from across the state and sometimes even out of state. That gets a little harder because it's usually Alaska Medicaid, so people have to have a residency first. One of the hardest things about actually getting people to come to Petersburg for long-term care is if they have family in the community they're in, they don't want to leave their family. So a lot of the people that we have, you generally would admit, are people maybe that don't have as strong of a family support and are willing to leave their home community to come here. And sometimes it's coming just for a few months until a bed opens up at home. We definitely have had a lot of people from like Prince of Wales Island, Haines, different places, some of the smaller facilities that don't have a long-term care. And then, they talk to their families or friends, and then they say, oh, Petersburg is great. And so we end up getting a lot of referrals from places like that. So yeah, so we definitely, and have some avenues for, like you say, recruiting. I think across the state and probably across the nation right now, COVID's been really hard for people in long-term care because the Medicare and Medicaid services, so CMS, did not allow any visitation in long-term care facilities. And so there's a lot of empty beds because families, either took them out of long-term care to be able to either have them in their home or a less restrictive environment, or just didn't put people in long-term care that they normally would have because they didn't want to go through that, no visitation. So that's changing now. So we've already seen, since the things are starting to open up a little bit in long-term care, a few admissions in the last few months. So yeah, so I think, the census is variable, but there will always be a need for long-term care. There are just some people who need more care than their friends or family or an assisted living can give.
I have a question, and that is, and I can't remember in the discussions, if we looked at the potential impact of changes in other facilities in our region and how that would affect our long-term care population.
Yeah, I think that they did look at other services that were in the area. I didn't think that there was has a, still to this day, it's actually in the legislative, it comes up every couple of years in the legislation for certificate of need. It's called CON. And the certificate of need is a state. We support that because, you know, certificate of need is you have to apply with the state. And so you kind of can get your bed size and capacity based off of that certificate of need on certain kinds of services. If you didn't have a certificate of need process, some states don't, then anybody can come in that's a major corporation and set up shop and compete and just, you know, and a lot of times they'll end up bringing services that are highly reimbursable, and then they'll drop the ones that are subsidized normally by, you know, like community-based services is typically subsidized. You're doing something, whether it's home health or some community-based needs, mental health services. So those are, you know, certainly a process for the state to apply.
Well, I was kind of
depending
alluding
on
to
number of
changes in
beds.
Sitka, changes in Wrangell, and how those might potentially affect us.
Yeah, I don't think Jennifer, you'd probably know better than me. I don't think the bed size changed in Wrangell. Maybe it did.
I don't know that it did. If it did, it wasn't, I think their acute beds, like I don't think their long-term care beds changed much. I think their acute license for beds maybe stayed the same, but they have fewer rooms or something like that. But but they have started not offering some services that they used to that they used to order. So now we're seeing some of those patients actually.
Any other questions about long-term care? See, so this is sort of the operational overview. And so here, you know, as a critical access hospital, we have ER, and we grouped ER observation. So if you come into the ER and maybe the doctor doesn't determine you're sick enough to be admitted into inpatient, but they just want to observe you. That's called OBS. That's still sort of an outpatient, considered an outpatient service. Deliveries, when Petersburg had deliveries, I went back to 2006, you can see that. And then surgeries, which is colonoscopies and scopes. And then the second graph is the acute care. Now these, other than the surgery, these are non-predictable. So this is the flow of your, you know, when people come into the ER, you can't you can't advocate that way. You have to be available 24/7. And this is what comes into the facility. And so you can see that, again, pretty stable overall. You're looking at, you know, the emergency is in the blue. The OBS are the darker blue. It's the smaller line above it. And then you have sort of the surgeries up there, which we are trying to get back in. That's a service line that's decreased in the last few years. COVID has completely removed it, but we want to bring that up. It's colonoscopies and scopes here. We do intend to bring those back in the future. And then deliveries are the one service line that's kind of, you know, you can barely see it. It's a very small amount back in the early 2000s. And then that was, I think, halted in 2008. So certainly before my time. And then acute care is your inpatient. It's acute. These are days. They count inpatient beds as in days. So how many days a bed is occupied? We have 12 beds. You know, you can have an average census of 1 in the inpatient, but then you can have at any given time, the range could be from 12 to 0. So you just never know. You could have your whole unit full, everyone's sick for whatever reason. And then there's a swing bed, which is what I was alluding to. Those are your rehabilitation, skilled nursing facility days. Those are a little more predictable if you can get, you know, if someone's coming back in and they get a hip done and they want to do rehabilitation, those are sort of the services you can do for longer stays. Under a critical access hospital rules, outside of swing bed, you can only hold somebody for 96 hours. It's called a 96-hour rule. Anything beyond that, it's basically saying that the level of care is a lot higher and you got to send them to your tertiary care facility. So those are Medicare rules that we have to abide by under that designation. Okay, let's see, long-term care. And here's our home health. And so this is a great example of, you know, so what went, what's interesting about COVID and what increased. And this was an interesting one because the demand was there. We were seeing that before COVID. You can see 2018 and 19, there was increased services in home-based or home health services. And then during COVID, it just skyrocketed. And those are just visits. You can see before that, up until 2006, very stable. It's just this tremendous growth in the past year. And, I asked our home health agency, what are you seeing? And normally a lot of these folks would come into the clinic over and over and over again. And it wasn't, so the home health agency is actually the right service for these patients. They shouldn't necessarily be coming into the clinic over and over again to receive their medications or their follow-up. Those are home-based care. So it's something that we've been able to accommodate. We've been able to grow that department and have more home health nurses and staffing in there to be able to accommodate that. And that was unexpected, but also it shows the ability to be flexible and to capitalize on that as the need arose. So that was certainly an interesting one.
Are you encouraging more of this home health?
100%, yes, absolutely. For two reasons. One, the need is there. We're obviously seeing that. And two is the community cafe. I heard that loud and clear from the community members here that they wanted more home-based services. We're actually adding a program. It's called Capable. It's not home health agency or home health services, but it's a between. It's a John Hopkins trademark program, and we received the grant. And basically, someone can go in, our facilities, our OT, and some limited nursing services will go into the home and assess the home and look at for like tripping hazards, handrails, some basic maybe maintenance things that can be done, and some therapies that can be done, and going in there and assessing that. And John Hopkins is trying to get that as a reimbursable model. Right now, we're doing a pilot with that program. We're the only ones in the state doing it. And it's actually very exciting because I think that's going to be a growth line. And ideally, I would then advocate for the state to be maybe potentially reimburse that, because keeping people out of the facility is certainly less expensive than keeping people in facilities. So that's why I think it's a growth area as well, because it's mutually beneficial for Medicaid and Medicare to help pay for these services.
I remember that line of discussion from that session. And one of the things, so my question about that, will this program just highlight what's needed in the houses, or is that actually somebody coming and installing those kinds of handrails and stuff like that?
Yeah, as well.
Cool.
We have maintenance right
Mhm.
now, helping with that as well as our OT, and Julie Walker's been running that program. And she can probably speak to that a little bit more, but it's really exciting. We got a small grant with the state, maybe $10,000 or $15,000 to help start it up and get it going. And I actually talked to the person who started it at John Hopkins, based out of Massachusetts, and really pretty interesting. I think that it has a lot of credibility, and it has some potential for the state to be able to maybe have that in between continuity where you can have savings but also get reimbursed for it at the same time.
Phil, can you talk for a minute about what you and the board see in the future for home health care here, or where you'd like to go, or what your discussions have been?
I've been talking about home health, this growth. I think every board meeting since I've seen this explosion, and I would love to see that line just keep growing. That's what I'd like to see. I think people like it. I think it's great care, and it's a way of, I think it's mutually beneficial. So there was I'm going to get a little long-winded here, but there's a leadership conference I went to a number of years ago, and they were talking about healthcare in general. And there was a speaker that I remember, and she was a physician, and she talked about end-of-life care. And, she talked about her dog. And she said, my dog was dying. I gave them, it was sad. We gave them a bed, had a favorite toy. I went out to the beach because the dog liked to go to the beach in the backyard. And then it was a reference back to our end-of-life care and healthcare. And it's like, our end-of-life care is more institutional. It's in a facility. Why are we not having those things outside the facility? So I think there's a big push for that nationally. I think it's something that we're seeing. And again, it's something that I'm able to accommodate and be flexible with, and grow. And that's exciting to me.
I think it's the benefit to to the family and to the patient is just so amazing, because no matter how many times you go to see the doctor in the clinic, or you're in and out of the hospital, they don't get the full picture. And when you go into someone's house, that's when you can get the full picture and you can say, okay, this one piece of equipment is going to make a huge difference in this person's comfort level and in how they can keep their level of functioning up. Or, this getting rid of this one cumbersome stumbling block that's in the living room or in the bathroom or whatever. And you just, without getting into the home itself, you miss that piece.
To get another aspect of Bob's question, are you including telehealth and home health care? Because you have advocated since you came on board, and that was not an emphasis of the previous administration, and it is taking off.
Yeah, it's definitely taken off. You read my mind a little bit. The other aspect of that is technology. You go into a home and right now, someone has to write down or their glucose or their blood sugars all the time. And now we have equipment that can calculate all that and then also give notification to our nurses if there's some reading or some vital that's out of sync. Or that's just one example of that. I mean, this example right now where we have Zoom capability. And, that wasn't possible. The bandwidth just wasn't there even about a year ago. So that continues to expand. The technology provides that access. It's not a replacement for, it's an add-on to. And that's always the way I looked at telehealth, is that it's providing more access and care. So yeah, we saw a tremendous explosion with that too as well. And these are some of the things that we decreased. This is our rehab department, our therapies. You can just see this again, 2006 to 2019, tremendous growth. Basically covers our PT, OT, and speech language pathology. And lots of, the trend line growth is important because that is a service line that's been growing quite a bit. And we saw a tremendous drop in that service, unfortunately. And then now it's kind of has a little bit of a rebound. So hopefully we can get back to where we need to for that, for therapies. This doesn't show up here really great, but this is our clinic. And this is sort of unfortunate that the color is not great there, but you can see that our services are just basic clinical services have been pretty stable over many, many years. In 2018-19, we added some additional services in the clinic and expanding some of the service opportunity, and some of those services are, mental health has been a big push in the last couple of years. We've grown that program. We have psych services. We have a nurse practitioner psych. We have a clinician. We just hired another clinician. And so we're expanding that services out of our clinic, and it's called integrated care. So the idea is through the clinic, if somebody is being seen, that there's availability for mental health through our clinic. The sharp increase you see to the right there is all the COVID related efforts that we've had. Oh, thank you. That's a lot better. So you can see a decrease in the early part of 2020 when COVID hit, and then all of a sudden you see it's like it's a great example of what we've been doing out in the facility. All the respiratory clinic, all the testing that we've had to do. A lot of the different colors are the different ways we've tried to deliver services through telehealth. And so it's been the different colors are an example. I think I call it the chaos. It's been very challenging to be able to do it, but we have been able to do it, and you can see how many different kinds of services we've had to do in the COVID year. So it hasn't just been a decrease line. Our staff been working twice and 3 times as hard in the past year, addressing all these all the things related to COVID. The vaccine clinic where, where the vaccine point of dispensing clinics in the gymnasiums and the recurring ones and the smaller ones in the clinic. We have upwards of 50+ % of our whole population vaccinated. I mean, that goes with a huge effort, organization. And Brian has been leading that initiative, and it's just that line shows some of the efforts involved in that, but it doesn't obviously show the whole picture. But it just gives you an example of our efforts in the last year. Anything else I want to add to that? Okay. All right, Cynthia, maybe you can talk a little bit at the finance. I have the financial slides up.
Okay, great. Well, yeah, there are about 5 slides here, and these are included to just give a snapshot of what has taken place at PMC. These are actually from 2018 forward through 2021, where we are year to date, on some of the key performance indicators. And some of these that you would have been seeing in the monthly financial package. There are a few that we pulled in from the National Rural Health Resource Center, which is kind of a think tank that specializes in critical access hospitals and financial performance and how to measure that. And so the first one here is days cash on hand, which is essentially tells us the number of days that PMC could operate if there were no new sources of cash. So if cash dried up, then essentially this represents the number of days the health center could continue operating without new cash. So when we look at 2018, the marker there was just over 100 days cash on hand. As the blue line is PMC, and the black line is actually the 2018 US median. And so this is not all US hospitals, it's all US critical access hospitals. And so that number, we just used it across the board there, but that was right at about 76 days. So PMC since 2018 has been above the US median, about 108 days in 2018. And then you can see it stays pretty level, dips down a little bit right before COVID, but that was still above the median. It was at 90 days right there at that 2020 pre-COVID. And then you can see a pretty sharp increase up to 2020 where the year ended. These are fiscal years, not calendar. And then dropping down to 2021, which is right about 200 days cash on hand at the end of March. And so this is a positive indicator. Higher is better, obviously. And the peak, as you would imagine, in 2020 was really related to the influx of the provider relief funds, Medicare advances, those type of fundings that came in related to COVID, much needed and greatly appreciated, I'm sure. But this is just an indicator that PMC has been doing above the US median average with days cash on hand, which is always a good thing. So another measure of days in AR net, and this particular measurement, lower is better. So this represents how many days it takes on average to collect patient accounting, patient AR. And you can see that the number was, so the median for this is right around 50 days, 51 days, I believe is the actual number there. And back in 2018, it was up sharply at about 86 and then dropped down in 2019. And this stayed pretty level there through 2019, 2020, and now is headed down to about 43. The big drop from 2018 to 2019 was due in part to 2 major reasons. There was an initiative within the revenue cycle and the billing office to implement some process improvements and really complete a concentrated effort on some billing practices. And then there were also some implementation of some change in accounting as it relates to the calculation of the net AR. And so, 2 things, one accounting related and one operational related, impacted that number. And so doing really well at 43, I anticipate that that number would probably stay there or perhaps even go a bit lower with some additional initiatives that are underway currently. But this is great because obviously the quicker the cash comes in, it's definitely related to that day's cash on hand number 2. The lower risk we have on having bad debt. And so the follow-up and the timely collection is really important. Operating margin, higher is better on this one. And this is really the relationship of operating expenses to profit from operations. It's a measure of the core business of patient care. And as you can see, back in 2018, it was actually negative. We were at negative 4.8%, increased a bit in 2019. In 2020, pre-COVID, it was at 1.1%, so a positive operating margin there, and then up a bit by the end of the fiscal year. That was due in part to the timing of, well, the very good performance up until COVID hit, and then also the recognition of some revenue relating to the provider relief. And then you can see just basically at a break even through March 2021, the median is 0.17. So pre-COVID, you can kind of see there's been a trend moving upward. Also in 2020, there was a positive adjustment relating to pension that had to do with how the PERS is recorded from an accounting perspective. And so that contributed a bit to the end of 2020 being up significantly as well. Next up is debt service coverage. On this one, the indicator higher is better. And this is really a measure of the availability of capital after debt service. And so the median is 3.43. And you can see there's just generally a steady increase there from 2018, just over 1 up to 14.5 in 2021. And this is related to 2 factors, the positive experience on the operating margin we just saw, and which generates the availability of cash, and the reduction of the principal owed on debt, which is essentially some capital leases. So there's literally, aside from the Medicare advances going forward, the organization, as you know, has just a very small amount of debt currently. And the last measure is age of plant. This is one that we don't have in the monthly financials, but it is one of those included by the Rural Health Center as an indicator of financial performance. And what this measures is, it's basically the average age of not just building, but also equipment. And so as you can see, PMC's number there in the blue has been at or above 25 from 2018 through 2021. The US median average in 2018 was just over 11, so 11.5. And so this is an indication that the average age of plan at PMC is more than double what the US median is. There is some literature that of course ties into the age of plant. The reason this is included as an indicator is that there's literature and analysis that shows that a newer build and newer average age of plant actually lends itself to better financial performance for a variety of reasons. So I believe that was the last one.
Yep. All right, thanks, Cynthia.
Sure.
Does anyone have any questions for Cynthia? Okay, so I have 2 more slides, and basically what is sort of the next, what's been done to date related to new facility, and then the next slide, the last slide, is sort of what are the action items to kind of keep the process going. So to date, we have the master plan completed. We had permitting from the Corps of Engineers for the geotechnical work on the 3 sites that were on there for the greenfield sites. The construction and, one of the things that, one of the bullets here related to construction is obviously economic growth. I mean, that's a pretty standard bullet in a lot of construction projects and infrastructure projects, is it boosts the economy locally. I've certainly lived through that. I understand that. 2008 ARA funds, when we had the new facility, there was a tremendous growth with the construction project that continued on after the opening of the building. And then, the COVID-19 has been really interesting because one of the questions I like to think about is, how's healthcare changed and what's going to stick around after we come out of this and as we turn the corner. And one of the slides I talked about was the home health aspect of that. Mental health is something that I'm certainly staffing up a little bit on. There's going to be, there will be a lot of grants coming down related to mental health. It's certainly an area that we need to address. It's going to be very important to address that going forward within our clinic. And so I'm excited about, providing some of those services. But also looking at infection control standards, the indoor HVAC systems in new hospital construction. I would expect that to probably change. Negative pressure rooms, I would expect to probably be sort of a new CMS reg on new building and new infrastructure. So it's going to be interesting on how the healthcare standards and CMS standards in our surveying will address the new infection control issues going forward. So that's still yet to be determined in the next phases of a construction or a new facility. And so where are we basically? And so the big perspective is it sounds like a lot. If you look at this 10 years ago, there was a long-term, Bettersworth North actually did an assessment for long-term care, looking at a renovation project or maybe a long-term care as a separate facility. Even back then, a new facility, I think it was quoted upwards of 77 million as turnkey was one of the slides in there. So that number just, healthcare is not getting cheaper, unfortunately. It's getting more expensive. So how do we avert just sort of a crisis situation? Our plant is aging. We're on borrowed time for sure. I think everyone sort of agrees on that. If you don't believe it, then you haven't done a tour of the hospital. I can show you the oldest elevator in the state in operation, which is something either to be proud of or something really interesting. But it's definitely a matter of time. And so, how do we prepare for that? Well, we just look at the next step. So I don't look at the big chunk, regardless of whatever the future comes. What are sort of the next steps and how are we going to get there? And so really it's about, our debt capacity. We're not able to do that. We don't have the funding to do that. I'm certainly not going to say, hey, community, pitch in, let's raise your taxes. That's not something I want to do. So how do we do that? Well, we look at it in phases and we look for funding and advocacy for state and federal capital infrastructure. We have a unique opportunity right now. That's how the building I was involved was funded through the 2008 ARA funds, same concept. And so we're looking for support and unification. And so looking at site selection is sort of the next step. Environmental study is the next step. Site acquisition, documentation, and then site preparation. These are really the next steps into this next phase. And so are we going to go and get $82 million or $85 million? No. I would recommend this is in a phased project. This is in a, something that you would do piecemeal, something you look ahead for in the next 4 or 5 years. If we happen to, the shovel readiness, I'm sure it's a term you all heard, is the way you obtain funding, and unification and support for that is also how we get funding. No legislator is going to support a project that's not fragmented or not unified in its approach. So that's my ask for today. Again, with the board's permission and support. I mean, it's something that we want to have as a common denominator going forward and trying to obtain some funding and moving that forward. questions about operations and, you know, changes in operations. Those are not things that you need to decide on today. I mean, if you look at Ketchikan, for example, Ketchikan has a project, the city owns the building and it's Peace Health operates out of that facility, and that's what they decided to do. And sometimes they, you know, they're talking about doing an RFP in the study. I mean, there's many options for healthcare. Of course, I support it locally. I think it's the best care. I think financially, if you look at that, the pre-COVID curve, operating in a margin of 1.62%, that's pretty good for as you're doing growth, as you're growing the infrastructure and economics of the hospital and providing those services, having a 2% margin. No, we'll probably never have a 10% or a 15% or 20% margin. We're not for profit. We a true up system, and we want to be able to have good growth and good healthcare in the facility. I feel like a new facility with the capital add-on concept and a cost-based reimbursement, there's no reason to not believe we could do that. That's all I had.
Phil, can I ask you a question? Just to put a fine point on it if possible, you know, you finished up that last, you know, paragraph, like, that's my ask for today. So you wouldn't mind put a fine point on your asks so that I can make sure I'm responding to you honestly and accurately. Your ask.
My
What's
ask is
what
just supporting the concept and moving the project forward. So supporting the concept means that the site selection, environmental study, and thinking about moving into the next phase 2.
Excellent. That clarifies it for me. So then speaking for myself, and you definitely have my support on that of everything you spoke to. I think the value of a community-based hospital, you know, if possible, because we're operating on the one piece at a time and trying to move forward is truly the best interest of all the residents of this community. So yes, is the short answer from me. And thank you, sir.
I think if I was going to make a comment, it would be that this project will never get cheaper. And so if we're going to go in this direction, we've got to keep moving forward on this. Because if we don't, then we've got to start deciding where we're going to go as a community with our medical facility and our medical treatment. So I guess for me, it's just, we've got to try. And if we don't, then we've got to really start evaluating where we're going from here.
I definitely support the concept, but I'm still kind of in the fog about how we pay for it. I know we're going to be going after federal and state money, and I know that we currently, as an assembly, put it as one of our top priorities on our capital projects list. So how does this all happen? We're going to apply on the next step here. I assume since it's borough property, that would cover whatever is required for a local match. I mean, what do we have? What do you see that we need to do to get this thing funded?
You know, and I guess I would ask to know what clarification on how that works with the, I would assume it's just an in-kind contribution on the borough side. You know, an environmental study, geotech, environmental study, and site selection is definitely the next step, because until you do that, you're not, you know, and then the acquisition of that. And I don't know that process, but I would assume there's some formalized process within the borough to be able to do that. When I talked to Steve about it, it didn't seem like that even had to go to vote necessarily. It's just something that could be moved forward if the assembly desired. But again, that's where I'd ask your guidance on.
Well, the one thing we have in Petersburg that very few other communities have in the region is we have a lot of land, which is a very rare thing in Southeast Alaska. So I wouldn't foresee that as being the problem. I guess my question is, where do you foresee, or how are we going to get the grant money to proceed with the next steps?
Yeah, I would, you know, I'm very persistent. I went to the Denali Commission. I did apply for the master planning last time, and they were very supportive of a project there. I had talked to USDA and I had talked with Denali Commission. They also, and Rasmussen Foundation, they're all very supportive of potential grants. I've even, the Denali Commission is looking at actually doing sort of some different initiatives as part of the executive branch. So there's some partnership opportunity there. It's helpful to have a conversation around whether it's a grantee like that or USDA or legislative office, if there's support. So my advocacy would be for grants and for federal and state funding to support the next phases. And that's, I mean, I wouldn't ask for anything else. I mean, there's really another option. And those, if you bite them off in chunks like that, it's not, it's 5 million to do site preparation, full design, geotech. I believe we estimated on the high side of 16 million, 12 million to be able to do complete shovel readiness. That means, moving the muskeg, depending on how much that is, building out the sewer water lines, the utility, building everything out to the point where you really are shovel ready to the construction, to build the construction. And so in those phases is the approach, and pursuing grants, state and federal and legislative support to be able to do that.
So if I understand, well, like I'm familiar with the Rasmussen Foundation. I know they like to see skin in the game when they give grants, depending upon the project. And, that's what we have to sell the community if we move forward with this, because if we have to come up with local tax dollars, that isn't going to be a very easy thing to do. But if we explain it, maybe we can, I don't know. But I guess my concern is, and I guess you've explained it, that we're going to do this in stages, incremental stages. And we're going to try and get the project to the point where it's completely shovel ready. And then hopefully all of a sudden we'll find somebody that come along that will give us or grant us 40, 50, 60 million dollars to build a facility at that point. Is that how you see this kind of happening?
Yeah, I mean, so
Okay.
I see it in phases. I see it in a couple of different ways. Again, I think in order to get to the next phase, we have to approach it to complete this phase, so in order to think about an $80 million building, we have to select a site. We have to have unified support. We have to be able to go and go to grantees to be able to obtain that. USDA has a direct loan program for facilities. I've talked to the USDA since I've come here. We certainly would potentially qualify for something like that. Now, it's a loan program, so I'm not as excited about that, but they would have this, 50, 30-year, 40-year, really long-term loan with low interest rate that potentially could support project like this. It is something that's available out there. I would prefer to have a team approach where you have some grantees around the table to be able to pursue the funding in stages. If you look at that budget, it's not an all-in-one. I mean, you have the 5 million for site selection. You have you have the design, the full architectural design. You have the geotech. You have the environmental study. You have the infrastructure piece, the site, the site prep, and then you have the construction, which is sort of the brick and mortar part of that. And then you have the equipment that goes all in there at the end, and then all the finished work that comes around that. So you can, that turnkey. Each one of those stages support Rasmussen. When I had spoken with them, they like to fund the FF&E, which is the furniture, fixtures, and equipment. So that construction projects. So in order to build a team of funders around the table, we have to have, community support. We have to have assembly support, we have to have board support. And I don't have a magic, key saying, oh, this is where we're going to get the funding. What I'm saying is that I believe in the phase approach, we can get the funding that we need to. And the alternative is not really that encouraging for a couple of reasons. If we're looking for greener grass, I just don't think that's greener grass. Either we decide that as a community you want to support this or we don't. I don't think there's good alternative solutions to that. I think we can do this. I wouldn't be here if I didn't think we could.
I guess that's what I was wanting to hear from you,
Yeah.
since you're definitely driving this train. You know, that if you feel that if by doing an incremental approach like you've laid out, if you feel confident, I mean, I know you're not going to give 100% or something, that this is a doable project. Because this is a big project. $80 million is a lot of money for a community of 3,000 people and a few more hundred.
Yeah,
You
and the
know,
first thing
so-
I would do is argue, how can we reduce that cost, you know? So for example, $82 million. All right, so where are we looking at? 1,100 square footage. Square footage is very expensive. What could we potentially do to reduce that amount? You know, could we do a 2-story instead of a single story? Single story has a, you know, bigger pad. So if you have a 2-story, it's going to reduce rate. So the next phase is really looking hard at space programming, really looking hard at full architectural designs. So, you know, can we potentially look at things, you know, like, you know, when you build a hospital, when you're housing somebody 24/7, that's called eye occupancy. That eye occupancy rating is expensive. That's where really the $1,100 come in. But I mean, I gotta tell you, there's gotta be business occupancy structures that we can build for half that. I mean, it has to be. If I go to an architectural firm, they're gonna say, you know, but there's gotta be ways we can get creative around the table around this, where I could say these outpatient services are business occupancy, we can build this structure next to this. Maybe we tie in a training center with the UAA, maybe we tie in childcare. You know, there's funders out there where if we get around the table and think about it, I don't think it's going to be that bill, you know, hopefully not. And if it is, I would like to see funding for it. But if it's not, you know, then what are the alternatives? You know, all right, well, let's look at business occupancy structures. Let's look at, you know, you know, so there's different conversations to have, you know. So right now with the master plan, this is the big number. And then now we just work down from there. That's how I would approach it.
I have a question about the, you know, putting one foot in front of the other, say the borough is designating land for the project. Would you prefer to do a site selection process together that way as the next step? Or would it be the borough saying, please take the land that you decide will be the best and you work out the details yourselves? Like, how do you imagine that exact process
I
working?
think that one should be a financial decision. Like if
Okay.
we do a geotech and there's one lot that's gonna take, you know, and I'm not a muskeg, I'm not an expert by any means on any construction around here, but my understanding is muskeg's pretty spendy. You gotta remove muskeg, you gotta backfill it, and then it displaces water, right? So,
And the other thing is
Where-
utilities, Phil, how you get your utilities there
Right,
and how you go,
utilities, right.
that's a big expense.
yeah, no,
Yeah.
I remember the project, you know, the Nome project was, you know, the idea was to build it on a hill, and then the sewer line was so much a foot, you know, they're immediately moving it closer to the road is how you cut costs. So totally. Yeah. So looking at it from a cost perspective to me, makes the most sense from the lots. You know, what cost the cheapest based off the geotech? Is it, you know, what has the most, you know, or least amount of muskeg, I suppose.
I think from my perspective, Phil and the board are at a point now that they need a decision. Are we as a community are going to support, you know, moving forward with what they're doing, or are we going to go do something else? They've spent quite a bit of money, you know, on doing the studies and looking at their future needs of the community and stuff. I think you got some of those studies. But I think that from our perspective, I think we have to, and I've talked, the manager and I both talked to our attorney and so forth. Yes, we can dedicate the land with no problem at all. We don't have to go to the voters. And yes, we could do some other things if we wanted to with that, without adding any more cost, you know, raising taxes or doing anything else. These are simply would be in kind, you know, essentially donations for the project in total, if we wanted to do that. But I agree with what Phil says. There's a lot of work to go on those sites before you get to that point. But we're at the point, I think he's at a point now, we either have to be in or be out, one or the other.
Well, I think it's important too to remember when we were talking about this project a few years ago, I think the price tag was about 20 million less than it is now. As we continue to drag our feet, those costs are going to go up. As we continue to drag our feet, there's going to be increased maintenance costs that are needed at the hospital just to keep it functional. If we don't keep it functional, it's over 100 jobs that walk out of this community, and that affects quality of life in Petersburg. And those are all important things.
Yeah, I mean, yep, I agree with you. All those.
And the other thing that Cynthia mentioned it when she was doing her recap, but the fact that we can get reimbursed at a higher rate with a new facility wasn't something I had even thought about until you brought that up at a board meeting some time back. So that also weighs in favor of moving ahead for a new facility.
Yeah, your capital add-on helps support like your loans and things if you take that on that.
Phil, for me, I don't feel like I'm dragging my feet on this. I think when that $84 million price tag popped up and a couple of months ago, we've moved this project to like our number 4 capital priority list, and there was no discussion with it. And I thought, thinking to myself, okay, we're all in on this project. And me personally, I'm not all in on the project. I know we need to do something different, but I have to be able to tell the voters in the community that this is a good idea. I'm sure all of us have heard about the fire hall, the aquatic center, this building, the library. I know they're all different funding things, but if the assembly is going to get all on board out here, we have to be all on board. We have to have all the questions answered so that when we do get questions from the community, we're going to be able to help sell this program. I mean, obviously the hospital board is an autonomous organization, but they're going to need all of us on board with this project. And if just myself, if I'm not totally convinced that there's funding out there to do this program, I'm going to have a hard time selling that. And that's why you heard Dave say, if we're going to do this, we're going to do this in phases. Well, that's fine, but the overall project's going to cost this amount of money. And that's what the community is going to be looking for us and you to tell us how we're going to be able to afford it in this, like Dave said, in a small community.
Excuse me, one of my concerns is how we're gonna fund it. There's discussion of, going to the legislature and getting money, and they're having a hard time even figuring out how they're gonna run their operating budget. So I don't know that there's gonna be, I'm not trying to be pessimistic, but it doesn't appear like that is gonna be a funding mechanism. I agree with the concept of a community-run hospital, but seeing how many of them are failing around the country, and like the discussion was earlier, being taken over by, Peace Health or Search or whatever, before I could support moving forward with, giving land or support for it, I would like to have a discussion with other entities similar to this that could, say what they have to offer. I'm not trying to, I know the jobs are very important in this community. Healthcare for me in the long term is what I'm thinking of in this situation. What's the best option for the people in Petersburg for long sustainable healthcare, and what's affordable? How can, currently in the situation, if I'm not mistaken, if there was grants or loans to the medical center, Petersburg, basically to build a facility. And if we couldn't, hold true to that financial obligation, would that fall back on all the residents of Petersburg? So I think it's I know the longer we wait, the more expensive things get, but even moving forward with this phased approach, how many, is it could be a decade out, or is it going to be, it all depends on where the money comes from, or if it falls out of the sky, or where, whatever. But I think we need to have some, maybe the community will give some input to the assembly, and I think it's important that we have 100% buy-in. Well, probably never get 100% buy-in, but community
Didn't we
support.
actually have, Search did a presentation. I think one of the things that's been a problematic for us is our PERS liability. And nobody wants to touch that.
Well, I don't know what the situation was in Wrangell, and I know there is a PERS liability, but you have to do a termination study to determine what that actual number is, I believe. I haven't been involved in any kind of discussion with anybody from Search or Peace Health or anybody else.
Yeah, but they did a presentation. And talked about how what they were going to do, some potential here, but it didn't go anywhere.
I also met with you.
So hang on one second.
You guys, there's something wrong with the audio. I don't know if anyone else has a problem, but I can't.
Yeah, I have the same problem. It sounds like you're robots or something. I can't understand a thing.
Debbie, I don't know if you can hear me, but yeah, we can't hear you in the assembly chambers at all.
You're welcome.
Speaking, and you didn't touch your mic, so it wasn't.
No, I was.
You ruined it, Mark.
But it's
Blaming you,
not-
man.
Hey, we can, hey, I don't know if you,
That wouldn't be the first time I've been blamed for something.
What's that, Steve?
Same here.
I'm gonna say, you guys all sound great now.
Is it this microphone? No.
I don't know. It's gonna be the feedback guy. I don't know.
Oh.
Yeah.
I mean, it's as clear as it was throughout the rest of the meeting now.
That's good. So anyway, that's just my input on it. So I just still have a lot of questions and, maybe my mind would change if I had conversations with other entities that, could potentially provide medical a facility or service for the community for the long run.
So I want to highlight the comment that Dr. Hess added into the conversation. The physicians at PMC currently strongly against the idea of a larger entity, particularly Search, taking over our facility and feel that we can provide better care with local control. And I want to highlight that because happening right now with a change in management of a local care provider, particularly mental health, there is now, and I don't know exactly what's happening there, so I don't mean to speak out of turn. It could be completely unrelated, but there is an entire staff turnover happening in this very, very essential piece of our community health infrastructure. So for me, I hear the frustrations and I get this, like, when we look at this big number and this big project, I get that it's overwhelming and we want to have all the answers right now, but we just have to walk into the doubt with this together because I don't see any alternative. Like my generation, we're trying to have kids, we're trying to think about our future. If we don't change this facility, if we don't make progress with this facility in the next 10 years, we have to plan a community without a community-run hospital, basically. We have to plan a future without that, those jobs, without that access to care. And to me, that means planning a contraction of our community. And I'm not interested in that. And so I understand that there's a lot of pieces at play, but to me, the phased approach makes all the sense in the world. And so just figuring out how to put that foot in front of the other is where I'm coming from, because to me, the alternative is kind of unthinkable. All the things that are difficult with healthcare right now are made much harder without community input and decision-making ability. Like if we have a healthcare provider that we don't get to share our frustrations with and demand timely response from, like all these kinds of things just get more difficult. And so same thing, that no matter what, this facility is going to be expired. So eventually there will be a new location, whether or not it's community owned or private owned. So we're going to have that discussion of location anyway. So we're going to be having to do this kind of geotech work anyway. So for me, the buy-in to me is like just taking that one step together, unified, like that's what we need to be doing, while still having all these bigger questions of how to get the cost per square foot down, what kind of, just like the library did, they had bigger plans, then they shifted them once they looked at the reality of the site and what the community need actually was. So this is an evolving project, but it's one that we really, I think, have to, like that next step, that one step next that we're doing, we have to do. I don't think there's an alternative.
Well, and even if somebody took over the entity, we have to do something about the building. It's still going to require a new site and all of these steps, the next steps. So why not take those next steps?
Yeah, I mean, I think your point's well taken, Mark. I mean, Mr. Mayor, sorry.
Marcus,
Um,
Marcus, good.
I think if I was in your shoes, I would be saying the same thing. Here's I've been thinking about this as well quite a bit. I think the way to look at this is, and I met with Serge. I went up and I met with them last year before COVID. I was up in Juneau and I had the whole executive team. And to be honest, I had more questions than answers when I came out of that. I was not confident, that the services, operations, the impact to the staff, especially after the COVID year, there's no way operationally I would support another entity coming. I think we have the best staff. I've never worked with a better staff, I would go the full length for that one. But here's the way I look at that. I don't think, is this a public? Are we on the public? Okay. Let me think of another way to word
The previous staff is very jealous
Pantomiming
right
is an
now.
option.
If I think the option would be off the table going down the line. So for example, having the control in the community where we choose the site, the location, and if we can get enough money to do prep and we get that far along, and then let's say I do a terrible job and our operations tank, I don't think an RFP is off the table at that point. In fact, if we follow the catch a can model, let's say we even go down to further, as a community, having some control, having that building, for example, provides you with some level of control always. So let's say go down, we get that building, community gets the building. It's a community-owned facility such as Ketchikan. Then you have the option of providing an RFP for the services. So you always have control of who's providing healthcare in your facility. And so to me, it's a little bit of a win-win because, yeah, it's a big ask. It's a big number. No doubt about it. I think there is, I really do believe there'll be funding to move this project along, and I don't think it's going to be 10 years. I've seen examples all across the state, and I've been a part of them where funding comes out of the air. I am telling you, there's lots of opportunity if we're aligned. But moving the project forward, we need, as a community, if we're gonna say we need a facility, we do have to check where that facility would be from a site. So moving it along, like, okay, let's choose a site, let's try to get it prepared, let's try to get it shovel ready, and just move a project along that much. That to me, then we can come back to the table and see where we are after that occurs. You know, to have a organization approach a facility is one thing, but then operations is another, you know. Those are, you know, saying all of a sudden, having my staff hearing, you know, flippantly in some ways, because we've all thought about this, that we are going to look at another entity as an RFP. I get the side from the facility side, but from the staffing side, that's operations as well. And that's a big deal. That's a big change in those. And you'd want to weigh that considerably. I mean, because we live and breathe by the staffing in the facility. That's the thing I mentioned when, you know, that's the first thing I mentioned in coming to this meeting. Our physicians are core to that. Our nursing is core to that. We just had a pinning ceremony for our nursing staff here locally. These are the things that we want to support locally as a local community. That affects everybody. So separating out facility versus operation, I think is really important. I understand the number. I mean, it's a big number. It's something that we would have to all, we wouldn't have, I would say we wouldn't have a chance if we don't all support it. But if we all support it, I think we can move the project along. And I think if we get to this next phase, full architectural design, full space, even if we RFP it at that point, you know, you could potentially do that. But if we're unified to that approach, let's see what it brings, you know, and it just buys us some time. You know, the concern about an RFP is that it just delays the process too. So it keeps kicking the can a little bit. And I would advocate and support just moving it on to the next phase. That at a minimum, and then, you know, let's revisit where we're at.
So can I chime in one thing real quick, Bill? And I'll let others have the floor. I think you touched on, in my opinion, one of the short-term most important parts is whether we talk other entity or community, you know, hospital, even though that's a place I would advocate, is geotech and that dirt work needs to be done regardless of a site. That's separate and distinct from everything else. I thought you raised a very, very good point there. And just, I don't know, maybe a clarifier for the financials. I'll leave all quality of care out of this statement, even though it's phenomenal. But I'll think of dollars. Maybe this for the mayor and member Mucci, who were, you know, very rightly had concerns about big dollar amounts. Is, you know, Phil has made it very clear this doesn't, you know, want to be coming to the taxpayers and asking for much of anything besides like in-kind, land. And I would actually politely disagree with the mayor and Phil in terms of money falling out of the sky. Phil has made it very clear he wants to very aggressively search out grants at every turn. And that isn't blind luck. That's you and your staff working extremely hard. And they've stated that's the goal. And I think that's the only reasonable statement he can make. He's going to be working very hard to get that money so it doesn't, you know, doesn't come before people saying we want to raise their property taxes, because he doesn't. Of course not. Nobody does. And my closing thought on that is, and that's what he was hired to do. When Phil was hired by the hospital board, and any hospital board member, you line me out if I'm speaking out of turn, is you wanted somebody competent to take you guys that next step and the community that next step. And that's him. I think he's the wrong guy to bet against. We want him to do it. And ask that my fellow members consider that sidebar to all that. That's all.
So what will a shovel-ready project? What's your estimate on that?
The letter we wrote was to get it to the point where we could actually construct. Now, it's not foundation, would be, I think the estimation was 10 million, 12 million. And I think we wrote a letter for 16 with quite a bit of buffer in there, is what we wrote.
And if I can add to that, and in talking with Carl and stuff, it depends on the site we pick, the utilities and so forth, as Phil said earlier, depends on where you go, how you configure it, what square footage you have, et cetera. makes a big difference on the costs. And also even in your development costs.
I mean, you're looking at, I mean, $1,100 a square foot is a lot. Yeah.
Well, compare $1,100 to $200 a square foot now for a new house is what one of the new contractor just told me.
Don't think I haven't thought of it. Why can't we just build a, a big, warehouse style for some of our services? Maybe we'll,
How long will the site selection process take?
I don't know. That's a good, I don't know. I would probably ask the assembly on, the site selection geotechnical, we have the permits, I believe, and we're just kind of on a holding pattern right now. I don't think that is out of our bandwidth to pursue, the geotech work. I think we can line that out.
So you just need from us to say, start the site selection? I'm just wondering,
It's a work session. It's
Yeah.
not a. I
no,
would,
no, no,
you
no,
know,
I
yeah.
know. Well, I'm just trying to figure out what the next step is.
Yeah.
I agree with what Jay said.
Yeah, no,
And
I
then
guess if you go into the coffee shop, support.
Yeah.
I don't know,
Right.
yeah, I guess the next steps would be, I guess I would ask, what would the next steps be from assembly to select the site and is that a community vote or, I know it's not, you don't need a community vote, but is
I
that
think-
something?
I don't think we have to go, land's not the issue here. You just have to find the right site. And I think that's the first step. And that's what the geotechnical work would determine, correct?
That's correct, yes. Yeah, it would decide
And,
on which one is.
So it seems like, if the assembly says, yeah, let's start down this process, then the geotechnical work would determine where the site would be at, where the best site would be at.
That's correct, yeah.
So the first part in this process would be to figure out how much that first step is going to cost, which is doing the geotechnical work. And then what grant money is available for that.
Mr. Mayor,
That's covered under that 16 million
Right,
cost.
right, understand.
Probably have to put out some sort of an RFP and would be my thought process to
We-
analyze all three, the properties that were selected up by Hammer Recon, I would imagine, to see which is the most suitable to move forward if that was the wish.
That's
kinda
exactly
what I
right.
would
We actually
Is-
have an RFP being written by somebody as we speak in the last few
And-
months here to get to get prepared for that.
Mr. Mayor,
Go ahead, Steve.
thanks. As well as the geotech, because costs can get crazy in a hurry, it's also utility access. So it's the land itself, but then it's also the cost to get the major utilities that a hospital would need to that location. So, for example, you may have a piece of property that geotech's more expensive, but utilities are cheaper. So that evaluation,
Right.
I'm not an engineer, but would likely need to be all of that. In other words, access to all of the utilities, road building, and then also the actual physical characteristics of the lot itself.
Yeah, yeah. I think Bob was mentioning that too.
Yeah, we
Okay.
talked about that a little bit, Steve, earlier.
Okay, just wanted to make sure.
Treating water service size, sewer service size, electrical load, everything, so. before you-
Exactly. Thank you.
One of the things I think that would help Phil right now is if, when he goes forward to ask for money or for other service and stuff, I think a resolution saying that we would support moving forward to, for to get to a shovel-ready project. I'm not quite sure of the wording yet, but would definitely help him if he could wave that around or something like that around to help him do that.
Yeah, you read my mind, Member Lynn, as far as an appropriate formal next step from us as an assembly, if that resonates with you, Phil.
That makes, if it helped, that would help. I mean, the first thing that funders ask, do you have support? And having either a letter or resolution makes a lot of sense. Yeah.
If let's say a new hospital gets built, what happens to the old facility?
I asked the architect to add in demolition costs to that. The structural engineering was such that it wouldn't even be in the situation to get repurposed. So demolition would be the preferred. And that was part of that. That's actually in that budget.
The entire facility?
Yeah, there was, I can't remember all the details, but yeah, almost all the facility is not structurally. The interesting thing, if you want a little bit of what I thought was interesting, was the more structural one was the 55 building. The 83 wasn't built very well, apparently.
Built without an architecture, a bunch of locals went up there and framed it up, and that's what we have, and it's still standing.
Yeah, I couldn't believe when the engineer came in and he said, yeah, actually the more structurally sound is the one that has the poured concrete and the long-term care side of the building, so.
I think that was something at our last meeting that the mayor had asked for, is to make sure that we covered the demolition of that building, if I remember.
Right.
And I don't know, now it's not possible. A few years ago, I took a tour of the hospital. I don't know how many other assembly members did, but I don't know how many of you have actually been through that facility and seen the offices in closets and the, physical therapy going on in the hallway, because they do not have space. They do not have adequate space to operate.
To me, there's two scariest scenarios that I see is that we have some kind of a catastrophic failure and suddenly we cannot house patients in that building, either acute care or skilled or long-term care. The other scariest scenario as I look forward is we end up like Prince of Wales Island with nothing more than clinics and maybe you can hold someone overnight for 12 hours and that's it.
I share those feelings. I really do. But the cost on this thing is just that's the first thing I hear from people. How can we afford that? And that's, I'm fine with going and trying to get this thing shovel ready, but that question is still going to be out there on how we're going to pay for it. And if you're going to do grants and stuff, that's great. But I think everybody in the back of their mind thinks that, well, it might come back onto the taxpayers in town. We need to make sure that we have that covered.
As a one of the, chair of the board, I have no expectation that we're going to be able to pay for it locally. I just don't see how we possibly could. So there's nothing in my mind that says that's the direction we're going right now.
Fair, yeah. I mean, I think a portion, again, grantees are gonna want to see community support. A portion that would be fundraising, some of that. But from a tax, I wouldn't be a big proponent of that at all.
I appreciate that approach, and
Oh, yeah.
you've stated that many times, so.
Yeah, I wouldn't.
I'll just I'll concur with Jay that I really think you're the right person at the right time for this project.
Thank you. I hope in a few years. you can say this.
Well.
Interesting comment from Kathy Reamer up there. Yes, someone should read it.
We've worked with Icicle for more than 30 years. We've seen a lot of changes. Giving control to a larger company, one that is not even an American company, has put us into a pretty precarious position. They can get tired of dealing with us and just pull out. Then what? Giving up our hospital to an outside organization will be similar. Do we really want everything in our little town to be controlled by someone else? Someone who doesn't really care about our community. Also, talk to Wrangell and Sitka folks. They have given up their community hospitals. Do people like it, and has staffing changed? Thank you, Kathy.
I think it's a legitimate questions, but I don't think you can answer them in 1 or 2 years. I mean, I think to get a really good understanding of that, you have to look 10 years out, 7 years out. So
Phil, I have a question regarding the search and the mental health gobbling up of those services. What does that mean for Petersburg?
So I don't know all the details of that. All I know is that whatever occurred over there, those staff are now on mine. It didn't work out for the staff, so now I have now some more mental health people in PMC.
Which I have to say that like, I don't, and again, I don't know anything about that, but just, I'm very excited about the integrated care model. I think that that's a very important development for overall patient well-being in our communities. So PMC is benefiting from that transition, and hopefully overall care for members of our community only improves as we go forward, and hopefully it all gets smoothed out. And this is just because this is very much mid-transition time, and maybe it isn't necessarily for us to know about right now as it's happening. Blessings to everybody involved, and I hope everyone's taking deep breaths, but yeah.
I've asked a lot, I am very collaborative. I have asked a lot of questions about potential collaboration opportunities with other, and, when I met with Search, for example. The response isn't reciprocal. I mean, at that time, and again, I'm just saying from the meeting I had, it was very clear that the initiative was to just be the healthcare provider in all Southeast, basically. So, but that doesn't mean other opportunities wouldn't be on the table if for partnership. I just haven't, I haven't heard that, so, but yeah, I mean, I don't think that new move is a good example of, that's, I mean, if it's an example, it's not a good one. So we'll see. Like I said, I mean, time will tell. I think it's a little too early to tell on some of the other projects in all honesty. I mean, you kind of want to look at, with mergers and partnerships, you want to look at a 20-year history of somebody if you're going to go, because you're once you to use a marriage example, you tie the knot, it's it, you're married. There's no going back on that. So
Not that you
maybe
want
that's not
to.
the way to say it.
Not you want.
Well, we pretty much covered the topic at hand.
And so
Any
what would
other-
you,
Let's go.
so what would just be looking for a resolution supporting this in the shovel-ready project? More or less?
However that becomes worded, but that's not a decision we're making at this meeting.
No, I understand that, but I'm just trying to
So it's-
understand.
I intend to work with the clerk and other interested parties on crafting a resolution. Member Mucci, if that answers your question directly. Right on, and please contribute. Look forward to working on it with you. All right, cool.
All right.
Thank you,
So,
Phil, and
yeah.
everybody for coming. Everybody up on the Zoom meeting, thanks.
I'm so thankful that every council member attended this. That's,
Yeah, I
that
think
is
it
a good
shows
show
we're
of support
interested.
right there.
Is that me?
Very personality.
No.